Hello, today I'll discuss the one important uh, clinical entity day and practice, that is the urinary tract infection. And this urinary tract infections has the many clinical complication and the clinical features, and in which cases we need treatment and in some cases we do not have treatment. So let's see how to approach a case of urinary tract infection. Urinary tract infection. Urinary tract infection. First, what is definition? Definition, it depends on category. Then, what is category? Five types. One is uncomplicated, uncomplicated cystitis. Second one, recurrent cystitis. Recurrent cystitis. Third is acute uncomplicated pyelonephritis. Acute uncomplicated pyelonephritis. Third, fourth is complicated pyelonephritis, and fifth one, asymptomatic bacteria. Usually, definition of UTI, that is the presence of microbial greater than 10 to the power 5 colony forming unit. বল কি আনতে দিবি কি আনতে দিবি বল colony forming unit ঠিক আছে নামাতে টানতে দিস তো নামাতে টানতে দিস তো কমা দামিতে এরকম কথা ক্লাসমেটের না অন্য কিছু দিলে হবে যা খুশি আন দেন হুম কি ঠিক আছে এখানে পাবি না 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 এখানে কোথায় পড়ি আমি এখানে কোথায় পড়ি acute uncomplicated cystitis, women with the recurrent cystitis, women with the acute uncomplicated pyelonephritis, complicated UTI and asymptomatic bacteriuria. Then what is complicated UTI? Complicated UTI defined as a risk of serious complication and treatment failure. That is the treatment failure act or whether a patient have serious complication. Then we will classify this type of the complicated UTI. Let's see the table. We discuss acute uncomplicated, recurrent acute uncomplicated pyelonephritis and complicated, and at last on the asymptomatic bacteria. Then when the complication is happen, when patient with the male sex, chance of complaint high chance, when this is pregnancy high chance, poorly controlled diabetes mellitus, that is poorly controlled diabetes mellitus, patient will have high chance of development complication, and in obstruction, whether it is just renal cyst, fistula, stone, malignancy, stricture, that will lead to the complicated UTI. Functional anomally, that is the neurogenic bladder and a basically urinary place. This will cause the type of the complication. If you have any foreign body obstruction, all these causes, there are the 5 categories that causes the urinary tract infections. Let's see the causative agents. These are the causative agents of the urinary tract infection. The most important is the E. coli, that is the 70 to 95% is in case uncomplicated as well as the uncomplicated. So we will divide the organisms into two divide. One is positive, another is the negative. Then positive we divide complicated and uncomplicated, and negative we also divide complicated and uncomplicated. So first we'll discuss the negative. Within the negative, most common is E. coli, and it is uncomplicated. In uncomplicated it is maximum, in complicated it is also maximum. Other causative organism Proteus mirabilis, Klebsiella specialis, Heterobacter, Enterobacter, and Pseudomonas. Mm, Gram positive organism within the gram positive organism, in case uncomplicated, that is a 15 to 20% in Staphylococcus saprophyticus, that is the coagulase negative Staphylococcus saprophyticus, and 1 to 4% is the complicated. And in case of complicated, gram positive organism include the Enterococci. So what we have learned and I will discuss here. Causative organism. Causative organism. Divide positive and negative. Negative within negative, complicated and uncomplicated. Within this complicated, most common E. coli. Within this uncomplicated, most common E. coli. Also include Pseudomonas, Enterobacter, Within this variety, we divide into two categories of complicated and uncomplicated. Within the uncomplicated, most common Staphylococcus saprophyticus. Within this complicated, most common. Yeah. হ্যাঁ কি না না অসুবিধা আমি ভিডিও বানাচ্ছি পড়ার ভিডিও না কোনো অসুবিধা হচ্ছে না তুমি পরে কথা বলছি এন্টারোকক্কাস these are the enterococcus these are the enterococcus complicated and uncomplicated, and they describe the complicated and uncomplicated. Uncomplicated include the staphylococcus saprophyticus, and within the complicated, that is the enterococcus. Staphylococcus saprophyticus, that is coagulase negative staphylococcus. Let's discuss one important thing, that is the diagnosis of UTI. Diagnosis of UTI, when there is organism 10 to the 5 or more, then we will diagnose the patient of the cystitis, acute uncomplicated cystitis. But in case of cystitis, the definition will include greater than 10 to the power 3 colony forming unit per ml or more pathogens. In case of because in if we define the UTI by this 10 to the 5 or more pathogen, then we will miss some case of cystitis. For detection of cystitis, we should cut off our limit, that is greater than 10 to the 3 colony forming unit per ml or more pathogens. Let's see how to approach. First patient present with the acute cystitis, that is the definition 10 to the power 5 colony forming unit per ml, but in case of cystitis, and it is the 10 to the power 3. Then we detect the complicated, whether any uncomplication, whether any complication, whether there any uncomplicated cystitis, whether any complicated cystitis. For complicated cystitis, patient is non pregnant, then we use fluoroquinol. And for uncomplicated cystitis, we use 5-day regimen or nitrofurantoin. Dose is 200 BD. Or we may use the sulfamethoxyl and trimethoprim or phosphomycin. If we give the phosphomycin, we give a single dose. If a patient is pregnant, then we do not avoid or contraindicated fluoroquinolone. We use amoxicillin without clavulanic acid, single dose of phosphomycin. Doses of the drugs. For nitrofurantoin, it is the 200 BD. For trimethyl sulfamethoxyl, 160 by 100 BD. For phosphomycin, 300 one dose. Other drug in the amoxiclav and fluoroquinolone include the ciprofloxacin 500 BD and levofloxacin 500 OD and the ofloxacin 400 BD or 200 BD. 200 BD. If patient responds, then no need of any intervention. If no, then we'll do the culture. If culture positive, then treat according to. If culture negative, then screening. And culture negative, then detect other causes or any abnormality of the urinary tract. Abnormality of urinary tract, do the cystoscopy or think other causes. Let's see, when a patient presents with a recurrent acute uncomplicated cystitis. What is recurrent? The first definition. When patient present with the greater than two if, recurrence in within span of 6 months, or greater than 3 FP recurrence greater than, within 12 months, then we will describe patient have the recurrent cystitis. When we will diagnose the recurrent cystitis, then first we will consider some condition, whether we'll ask patient to change the spermicidal product changes, use all other contraceptive method, consider postcoital urination, or consider cranberry product cranberry product and then we'll evaluate patient whether patient is postmenopausal. If patient is postmenopausal, we give the topical estriol. We give topical estriol. If the patient not postmenopausal, then we'll prophylaxis. We give prophylaxis for this patient. If patient have UTI not related to coitus, and then we'll give the dose either daily or weekly. If patient related to the coitus, a UTI that is related to the coitus, then we give the postcoital dose. After coitus, we give this dose. What are the drug? Describe. I will now discuss what are the drug and include prophylaxis. For nitrofurantoin, it is only 50 OD or 100 OD after postcoital or daily. For trimethoxyl or sulfamethoxyl, it is the 40 by 200 OD. For Norflox, it is 200, but it is avoided in pregnancy or childbearing age. Nitrofurantoin, Moscioli, trimethoxyl, sulfamethoxyl, 40 by 200 use. Then we stop 3 to 6 months. Then if pattern returns, yes, then consider for greater than 1 year treatment. If no, then no treatment is required. So let's discuss uh, here. We'll discuss more clearly here. Re- recurrent UTI. And what is the definition? Definition: greater than two recurrence within 6 months, or mm, three or more recurrence within 12 months. Then we'll define patient has the recurrent. If the patient has recurrent UTI, then we'll give some advice: change contraceptive method if UTI is due to the postcoital. Second is mm, you use a method, uh, uh, follow a method follow a method postcoital urination. If this UTI related with coitus and not related with coitus. If not related coitus, give daily dose. Mm. Then give the daily dose for 3 to 6 months. Give the daily dose for the give the daily dose, and if not, then after postcoital dose after 3 to 6 months, you will evaluate the patient. If pattern returns, give the greater than 1 year. Now we will evaluate the uncomplicated pyelonephritis and complicated urinary tract infection. Then what is pyelonephritis? When patient will have fever, loin pain, tenderness on vertebral junction, the renal angle, will think that patient may be suffer of the pyelonephritis. Then we'll divide the patient whether patient is complicated or not. Whether patient is complicated or not. And if the complicated UTI, then we should hospitalize patient, and we do a urine culture and a blood culture hospitalization, and we do the hospitalization, urine culture and a blood culture, and then we'll empirical therapy with the parenteral regimen. And if uncomplicated, we also know we will evaluate the patient whether hospitalization is needed or not. If yes, then follow the same urine culture empirical therapy. If no, then urine culture do an empirical therapy with oral regimen. If responses happen within 72 hours, then yes, then we will switch to oral therapy. If no, then if no, then we review the culture. Second is the review diagnosis, and the other reversible risk factor. Evaluate the risk factors. Then we'll give the 10 to 14 days or longer treatment. If it will cure, then it is okay, but if not cure, then evaluate the case. Then what are the parenteral treatment we should give? we give ceftriaxone, that is the 100 to 200, and that we may give the ciprofloxacin, levofloxacin. We may give trimetazole, sulfamethoxazole, trimetazole, fuso, meropenem, vancomycin may be given, intrapenem may be given, imipenem, we may give for parenteral, for parenteral cases of parenteral, we may give. Not for uncomplicated pyelonephritis, we gave the ciprofloxacin, leofloxacin, thimerosal, sulfamethoxazole, and amoxicillin. We will give. Let's discuss one important thing, that is the renal abscess. Renal abscess. It may be cortical. It may be corticomedullary. Corticomedullary junction, whether abscess is present at cortically or corticomedullary. When it is present at the cortex, that is at the cortex, most common spread of infection is hematogenous. And coative organism includes Staphylococcus. When it is at the corticomedullary junction, source of infection is here. Then E. coli is the most common organism. This corticomedullary junction then rupture later and form, it will form when this corticomedullary junction, the abscess at the corticomedullary junction, it will expand and later it rupture, and the abscess will present behind the capsule or renal capsule, behind this renal capsule, and behind this renal capsule, and patient present with the P renal abscess, and present is the P renal abscess. In these cases, treatment, uh, in these cases we will give the IV antibiotic. In these cases we give the IV antibiotic, but in case of renal abscess we usually first give IV antibiotic plus percutaneous drainage. If not possible, then consider nephrectomy. So in case of renal, in this picture, here is a abscess, and here is this perirenal collection, perinephric space, collection of perinephric space. In this X-ray, we see the hair is air that is trapped, and it is this condition is known as emphysematous pyelonephritis. This condition is known as emphysematous pyelonephritis. Let's discuss about asymptomatic bacteria. What is asymptomatic bacteria? Asymptomatic bacteria usually definition is what is asymptomatic bacteria? When there is presence of bacteria 10 to the 5 colony forming unit per ml, that is the should include the one pathogen, and no patient have no symptom, then we'll tell the patient has asymptomatic bacteria. But there are certain conditions at which we do not, usually in case of asymptomatic bacteria we do not prefer for treatment, because recurrence and treatment may increase for risks of recurrence and risks of UTI. So usually we do not treat this type of patient. We only treat for high risk patients like if patient is pregnant woman or if the patient undergoing any urological surgery, then we will treat this patient. Whether again when the patient have some authorities prefer treatment for asymptomatic bacteria if the patient have been an anatomical or functional abnormality like urinary tract, like diabetic patient. In these cases, these some authors prefer for treatment of asymptomatic bacteria.